Hello, my name is Jennifer Stransko, and I'm the Physician Engagement Associate for MAVEN Project. Thank you all for joining us today and our friends at Mariposa Community Health Center for hosting today's session. ECG Mini-Series number 3, Atrial and Ventricular Arrhythmias by Dr. Charles Schulman. Dr. Schulman is a senior physician emeritus who recently retired from active practice after 53 years, but continues to teach and consulting. In addition, he has been practicing non-invasive cardiology since 1970. Dr. Schulman's scientific articles and abstracts have appeared in the New England Journal of Medicine, Circulation, the American Journal of Cardiology, and the British Heart Journal. His research interests include the treatment of hypertension, congestive heart failure, and hyperlipidemia. And with that, Dr. Schulman, you may begin.
Well, thank you very much, Jennifer, and good morning, everybody. Welcome to the third part of this webinar series on electrocardiographic interpretation. And today we'll deal with arrhythmias. Before we start, I have no disclosures, nor does anybody else that has anything to do with this with this activity. And the project is accredited by MAVEN for one category 1 hour of category 1 credit. So the learning objectives are that you have a general approach to arrhythmias, which we'll talk about, to know the differences between regular and irregular tachycardias, to diagnose narrow complex tachycardias as well as wide complex tachycardias. So my approach to arrhythmia management, diagnosis and management, is something as follows. First of all, look at the patient. There's actually no substitute for looking at the patient for a variety of reasons, but in this context, hold on. Sorry about that. In this context, what I mean is by looking at the patient, is the patient hemodynamically stable? If the patient is hemodynamically unstable, that person may need to have a tachyarrhythmia cardioverted, no matter what the cause is, and before you have a chance to actually diagnose it. On the other hand, if the patient is stable, then you can go on to looking at the ECG and other aspects of this. The other thing I mean about looking at the patient is, does the patient have structural heart disease? So do an echocardiogram. Arrhythmias mean one thing in the presence of structural heart disease, and another thing in patients who have no structural heart disease, keeping in mind that there are some arrhythmias that occur in people who have structurally normal hearts. Next, look at the EKG. And I put up here a systemic approach that's proposed by Ken Grauer, who blogs about ECGs, and actually his blog is has numerous patients and examples and so forth. A lot of ECG interpretation information. So he proposes 5 key parameters. Watch your P's and Q's and the 3 R's. The P, are there P waves? If there are not, are there signs of atrial activity, such as fibrillatory waves or flutter waves? Q, is the QRS wide? Is it wide or is it narrow? You're dealing with 2 different kinds of things in that setting. And the 3 R's, what is the rate? What is the regularity? That is it a regular rhythm or an irregular rhythm? And if there are P waves and QRSs, are they related to each other? And if so, how? Third, look for and treat precipitating or reversible factors. Things like electrolyte imbalance, ischemia, drugs, hypoxemia, hyperthyroidism, and so forth, and deal with those before you think about number 4, which is treating the specific arrhythmia. None may be necessary, but on the other hand, there are drugs, devices, and surgery which are available. So to start, we can talk about narrow complex tachycardias, and then later on, we'll talk about wide complex tachycardias. So the definition of a narrow complex tachycardia is a rate over 100 with a QRS duration of less than 120 milliseconds. These come in 2 varieties, regular and irregular. Regular narrow complex tachycardias may be sinus tachycardia, atrial tachycardia, AV nodal reentrant tachycardia, AV reentrant tachycardia, and atrial flutter. Irregular tachycardias are the most common one that we see that in any context is atrial fibrillation. Atrial flutter is usually regular or with some regularity, although it may look like it's irregular. And then multifocal atrial tachycardia, which I will show you. Considering the regular, narrow, complex tachycardias, again, QRS with less than 120 milliseconds, rate over 100, with visible P waves, you can have either a long RP interval or a short RP interval. So the RP is the distance from the QRS complex to the following P wave, or, and a long RP interval may be sinus tachycardia. It may be a focal atrial tachycardia. Short RP interval, as illustrated here, may be AV nodal refractory tachycardia, where these little blips are really pseudo. They're pseudo R. It's a pseudo R prime, but it's really a P wave, or orthodromic reentrant tachycardia. Okay, so here's an example of sinus tachycardia. This is a pretty fast one. The rate's 150 or so, but you can see sinus P waves. They're positive, right? Positive in 2, 3, and AVF. So the trajectory of the vector, P wave vector, is inferiorly directed, as it should be, from the sinus node, which is located at the junction of the right atrium and the superior vena cava. So the wave is traveling in this direction. There are some differences between what we call supraventricular tachycardias, or SVTs, and sinus tachycardia. An SVT begins abruptly. The rate is somewhere between 160 and 240, and it can be terminated by a vagal maneuver because it's often a reentrant tachycardia. We'll talk about reentry in a little bit. Sinus tachycardia, on the other hand, begins slowly in response to some physiologic need. The rate doesn't usually exceed 150, although the one I showed you was pretty close. If you perform a vagal maneuver, it is either unaffected or only momentarily slowed, and its offset is a gradual decline back into the normal range. So here's a 76-year-old man who happened to be hospitalized for a treatment for acute leukemia, who triggered for a high heart rate. And as you can see here, he has a narrow complex tachycardia. This is a PVC. but he has a narrow complex tachycardia, and he has a long RP, right? R to P. The P is almost on top of the next QRS, but you notice the direction of the P waves. It's negative in 2-3 in AVF and positive in AVL, which means that it is superiorly directed, not inferiorly directed. So this is not a sinus tachycardia. This is an atrial tachycardia. That's shown here. And the next day, when he reverted back to sinus rhythm, you can see that this is his sinus rhythm, and you can see the difference in the P wave configuration. It's positive in 2-3 in AVF, whereas the day before, it was negative in 2-3 in AVF. So that's how you know these are not normal P waves. Now, let's talk about reentry for a minute. Reentry is a mechanism of arrhythmia formation that is very common. And for those of you who are not familiar with the mechanism of reentry, consider a pathway, in this case, the AV node, but consider a pathway with a slow branch and a fast branch. And normally, a normal P wave, a normal atrial depolarization, enters this reentry circuit, travels quickly down the fast pathway, but very slowly down the slow pathway, so that by the time it gets here, it's refractory, and so there's just a single wave of excitation, and you have normal sinus rhythm. So reentry occurs when there's a block in the fast pathway. The impulse travels slowly down the slow pathway, and by the time that it gets here, this is no longer refractory, it's excitable, and so you get retrograde conduction and a circular, or the British call it circus, motion. And that sets off the arrhythmia as shown here. So here's the R wave, here's the P wave over here, showing it's a circular motion. Now, this can occur in many settings. It can occur in the atrium. It can occur around a scar. This shows a scar in the atrium, but reentry occurs in the ventricles, particularly during ischemia, setting off ventricular tachycardias, or typical atrial flutter is a reentry mechanism. So here's AV nodal reentry tachycardia, and what you see is these secondary R waves. Right, looks like an R prime of right bundle branch block, except it's not in this narrow complex tachycardia, and you can see the difference after adenosine. So here, let's see, you can't really see it, and you see it in V1, not very well, but you see these little negative P waves in 2 and in lead 2 especially, that are no longer present in sinus rhythm. Okay, so you see the second in sinus rhythm, this area of the ST segment does not have a deflection, whereas during the tachycardia it does. So that's a P wave with a short RP interval. Now here's a 37.
Dr. Schulman, I'm sorry to interrupt, but we had someone comment that they were having trouble hearing. If you could just speak up a little bit.
Okay, is that
Please.
better?
I personally am not having a problem, but I am also in a really quiet environment, so I don't know if that's what the difference is, but
Oh, all right, I apologize. Okay, is this better? I'm closer to the microphone now. Okay, is this better?
I think yeah, it definitely sounds louder on my end.
Okay, and in the conference room, can you hear me now?
Yeah, if someone could just put in the chat if you couldn't hear him better now. All right, I don't see any comments yet, but no, it sounds louder on my end. So I'll let you know if there's any other comments made.
Okay,
Okay, thank you.
okay, thanks. So here is not a narrow complex, perfectly regular tachycardia uh, with a bundle branch block appearance. We'll talk a lot about this when we get to ventricular arrhythmias. But what happened was after adenosine, there's sinus rhythm, but there's also a wide complex. And you'll notice that there's a short PR interval and a slurred upstroke to the QRS complex. This is Wolff-Parkinson-White syndrome. There are two reentrant type arrhythmias that occur with Wolff-Parkinson-White syndrome. So with pre-excitation, here's the sinus node, here's the AV node. This would be the normal conduction, but when the impulse travels down the bypass tract, it's a bypass tract called pre-excitation. Down the bypass tract, you get this short PR interval and delta wave. So the two forms of reentrant tachycardia are orthodromic AV reentry, where the impulse goes down the AV node and back up the bypass tract, giving you a narrow complex with a negative P wave afterward, or antidromic, where the impulse goes down the bypass tract and back up the AV node, giving you a wide slurred QRS complex, which is what I just showed you. These are Doctors Wolff, Parkinson, and White. This is from their original paper in 1930, showing a very nice example of WPW. Dr. White is widely regarded as the founder of preventive cardiology. He was an advocate for healthy living back in the 1930s when nobody else was doing it, and was one of the founders of the American Heart Association. Here he is riding his bicycle and the bike paths along the Charles River in Boston. There's the Boston side. This is the Cambridge side. This is the Boston side. Are called the White bike paths. So I gotta show you that. Here's a 73-year-old man who complained of palpitations and lightheadedness, and he has this regular narrow complex tachycardia. And this sawtooth pattern of P waves. You notice? Then leads 2, 3, and AVF. These are negative P waves in 2, 3, and AVF. And there is 4-to-1 AV conduction. 1, 2, 3, 4. Okay, so this is a typical atrial flutter. Here's another example of the same thing, and showing the flutter waves. Okay, and here he is in sinus rhythm, and you'll notice that the P waves in 2, 3, and AVF are upright, not inverted. See, inverted. Okay, so here we come to the most common arrhythmia that we know, that we see, is an 81-year-old lady who came into the clinic one day complaining of a cough. Her daughter thought she needed an antibiotic. However, an alert medical assistant noticed that she had a rapid pulse, and so she did a cardiogram, which is shown here. And what you see here is a narrow complex tachycardia at a rate of about 115 or so, without P waves. It's irregular. And if you see an irregular narrow complex tachycardia like this, you can guess that it's atrial fibrillation, because it is. As I say, the atrial fibrillation is the commonest arrhythmia seen in your clinics, in my clinic, in cardiology in the hospital, and among the electrophysiologists. So this shows the difference between sinus rhythm and atrial fibrillation. This illustrates normal conduction with sinus rhythm on the ECG, and with atrial fibrillation, there are upwards of 360 fibrillatory waves and reentry circuits that spread and bombard the AV node in an irregular fashion. And so there's variable penetration into and beyond the AV node, which is what gives you the irregular rhythm. Although we're not talking about management, with atrial fibrillation being so common, I thought I would just show you this from the most recent guidelines for the treatment of, for the management of atrial fibrillation. So consider stroke risk, okay, and anticoagulation. Optimize modifiable risk factors, such as lack of exercise, arterial hypertension, diabetes, cigarette smoking, obesity, ethanol, and sleep deprivation. And then apply symptom management to reduce the burden of atrial fibrillation. AF burden is the percentage of the time that a person stays in atrial fibrillation as opposed to sinus rhythm, either with rhythm control or rate control. So here's a 64-year-old woman who complained of palpitations, and she has a pretty rapid, irregular, narrow complex tachycardia without visible P waves anywhere. So this is atrial fibrillation. And the question is, what arrhythmia is it? The arrhythmia is most consistent with which endocrine disorder? Hypothyroidism, hyperparathyroidism, Cushing's disease, Addison's disease, or hyperthyroidism? Put your answer in the chat. Can we get to the chat? No, I can't get to the chat. No, no takers?
Someone said
No.
by
No,
hyperthyroidism.
There are a couple, and you're right. You're both right. It's hyperthyroidism. Hyperthyroidism is treatable, of course, and the atrial fibrillation is thought not to recur after you make the person euthyroid. Whether or not you should continue anticoagulation is a discussion, because it may depend on what the CHADS VAS score is. Okay, this is multifocal atrial tachycardia. So again, rapid rhythm, irregular, narrow complex, but it's clear that there are 3 different P waves here, which is the definition of multifocal atrial tachycardia. So the arrows here show 3 different P waves. There's one, there's another one, there's the third one, there's probably a fourth one. Okay, so you see these. So this is multifocal atrial tachycardia, not atrial fibrillation. This is not a common arrhythmia. It occurs in sick people, usually with pulmonary disease. Usually they're in the ICU, often on ventilators. The treatment for this is to treat the underlying disease, and not to treat the arrhythmia per se. This is what's called the sick sinus syndrome, tachycardia, bradycardia syndrome. So here's a person with atrial fibrillation that then stops. I think these 3 beats are the same as these 3, that then stops, and there is no sinus node recovery until you get over here, and there are a couple of escape beats, a couple more escape beats, and then finally you get sinus beats over here. So this is called sick sinus syndrome, or tachycardia, bradycardia. This person needs a pacemaker in order to treat their tachycardia. Now here's a 68-year-old woman who complained of shortness of breath and palpitations for a week. She has a history of hypertension, of chronic kidney disease, and coronary disease. And here's her cardiogram. You can't count the rate on this image, but you can see that it's a narrow, complex tachycardia with no visible P waves. So this is what arrhythmia. Put it in the chat. Put your answer in the chat. Sharon is right. It's AFib. That's right. So she has atrial fibrillation. So she's anticoagulated and then cardioverted back to sinus rhythm and felt good, felt great. However, 6 months later, symptomatic AFib recurred, and she's given sotalol 80 milligrams twice a day and is cardioverted again back to normal rhythm. She again felt well, but unfortunately came back after 2 syncopal episodes and had this cardiogram. What is going on here? Well, it's sinus rhythm. I'll tell you that. But what is it about this cardiogram that you should be noticing? You should be noticing, you're right, you should be noticing that the QT interval is prolonged. So a normal QT interval is much less than half of the RR distance, whereas a long QT is more than half. And this one, starts here and goes almost all the way over here to the next P wave. Okay, so then, what's the most likely cause of this syncope? Sick sinus syndrome, monomorphic VT, torsade de pointe, recurrent AFib, GI bleeding, or a stroke. Two or three. It's either monomorphic VT or torsade. What's the risk with long QT? Is it monomorphic VT? I'll answer it. The answer is torsade. The answer is torsade, and in fact, that's what happened. There you go, torsade. Torsade de pointe is polymorphic VT. Starts, it shows the points are down, then up, then down, all in the same lead, and this deteriorates, as you can see, to ventricular fibrillation. She was successfully resuscitated. I don't have information after that. But there are a number of clinically recognizable risk factors for torsade. Prolonged QT, the three hypos, hypokalemia, hypomagnesemia, hypocalcemia, the use of QT prolonging drugs, especially if there are two of them, if there are more than one of them. Heart disease, heart failure, advanced stage, and congenital long QT syndrome. There's a large list of drugs. This is why I emphasize this. There's a large list of drugs that pose a risk of torsade. This is, the list is, a page and a half, single spaced. So this is only a small representation of some of those drugs. They include antiarrhythmic drugs. It's actually the most dangerous side effect of antiarrhythmic drugs. Antibiotics, which you should be aware of because we all use antibiotics. Especially giving people who come to the emergency room with a chest X-ray that might have heart failure, but might have cannot rule out pneumonia. The radiologist tells you cannot rule out pneumonia. So the patient is given azithromycin and they happen to be on another QT prolonging drug, and that's the sort of thing that can do it. Antidepressants or antipsychotics, and a number of other things, including methadone, cyclobenzaprine, hydroxychloroquine, and ondansetron. So that leads us to ventricular arrhythmias. And, some of these things sort of stick out like a sore thumb. I call them funny looking beats, FLBs. Are they truly ventricular? That is PVCs versus PACs with aberration in terms of wide complex tachycardia. Are you dealing with VT? Or are you dealing with SVT with abnormal conduction? Definitionally, VT is more than 3 PVCs in a row. So here are some of the differentials. Here's a ventricular couplet. This is bigeminy. This is trigeminy, and this is ventricular tachycardia right here. In terms of the PACs can be conducted normally, or not conducted at all, or conducted with a right bundle branch block configuration of wide complex. So here, which is called the Ashman phenomenon, which is aberrant ventricular conduction due to refractoriness of the right bundle. So here's atrial fibrillation, as described originally by Dr. Ashman, with a long pause and then a short RR interval and right bundle branch block configuration. So if you think about it, there are 3 fates of a PAC. Consider this is the QRS, this is the QT interval or the recovery period, and the recovery period of the right bundle is longer than the left bundle, so that a beat that lands here at number 1 isn't conducted at all. One that lands at number 3 is conducted normally, and then one that lands at 2 is conducted with a right bundle branch block configuration, and that depends on rate, right? The QT interval and the recovery period depends on rate. So at a faster rate, the recovery period is shorter. At a slower rate, the recovery period is longer. So after a long short is when you get this aberration. So this is true aberration. So considering ventricular tachycardias, number 1, treat unstable patients as if the rhythm is VT until proven otherwise. Okay, I mean, you'll be if you guess, you'll be almost always right. For stable patients, is the rhythm regular or not? If it's atrial fibrillation, more than 90% of well, if it's irregular, more than 90% of them are atrial fibrillation. If it's regular monomorphic VT, 80% of them are VT. If it's regular monomorphic wide complex, 80% of them are VT. What's the QRS axis? Is there AV dissociation? And is there a history of heart disease or other arrhythmias, which make it more likely to be wide complex is VT? So here's the axis, and the one we think about most is this right superior axis, so-called no man's land or northwest axis. That's almost always VT. This illustrates AV dissociation. So the red marks are the P waves. You'll have a wide complex rhythm faster than the sinus rhythm in this case. Okay, and so you get occasionally, if the P wave hits the AV node at a time when it is not refractory, you'll get conduction and a narrow complex beat called the capture beat, or a beat that's fused, so somewhere in between the wide complex and the narrow complex. That's a fusion beat, and fusions and captures demonstrate AV dissociation, and the tachycardia is ventricular tachycardia. So in the differential diagnosis, we can look at several aspects. One is the Brugada algorithm. If there is both an R and an S wave present in the precordium, then I go to if there is not, that's VT. If there is, look at the distance between the beginning of the R wave and the nadir of the S wave. If that's more than 100 milliseconds, that's VT. But if it is not, look for AV dissociation, which I've just described. And if not, look at morphology. And these are some of the morphologies looking in V1. A right bundle branch block with this RSR prime rabbit ear favors supraventricular tachycardia, whereas these appearances favor ventricular tachycardia. And if you look at V6 and you have a deep S wave like this has got to be VT. It's got to be. There's another example of it right here. In terms of left bundle branch block, narrow R wave prompt downstroke suggests supraventricular tachycardia, whereas fat R wave and notch on the downstroke suggests VT. Again, you can play the odds. If the wide complex tachycardia is regular, and it's mostly VT. If it's irregular, it's mostly atrial fibrillation. Thinking about the common causes of monomorphic regular wide complex tachycardia of uncertain etiology, the number one diagnosis is ventricular tachycardia. The number two diagnosis is ventricular tachycardia. Causes number 3 through 8 is ventricular tachycardia. And cause number 9 in terms of frequency is SVT with a pre-existing bundle. And last, SVT with aberrant conduction. People call it SVT with aberrant conduction, and really most of the time it's SVT with a pre-existing bundle branch block. So here's an example of a ventricular tachycardia with fusion and capture beats. Okay, so the P waves are marked in red. Here's a capture beat, right? So the QRS complex resembles that in sinus rhythm. This is a fusion, something in between the tachycardia and the normal configuration. So here's an 87-year-old man who complained of chest pain and shortness of breath. He got admitted to Beth Israel Deaconess Medical Center. Yes, terrible heart disease, hypertensive heart disease, coronary disease, heart failure with a reduced ejection fraction, and a prior CVA. And so he has a very abnormal ECG to begin with. Okay, and his QRS complex, his QRS axis in the frontal plane is rightward, but inferiorly directed. He has a right bundle branch block to begin with, okay, and this is sinus rhythm. A week later, he triggers for this. This is also a right bundle branch block, like tachycardia, pretty fast actually, greater than 150, okay. But you notice two other things. Number one, northwest axis, negative in 1, negative in ABF. And you also notice V6. This has got to be ventricular tachycardia. Okay, right, superior axis. There you go. Okay. Here is an 85-year-old woman who presented with severe aortic stenosis, who presented with syncope. She has severe aortic stenosis. She also has a right bundle and a rapid rhythm that is regular or not regular. Not quite regular. Look here, not regular. Okay, not regular. So if it's not regular and irregular, that's probably a fib. Here's her previous in sinus rhythm, and she has a pre-existing right bundle. So at a rapid rate, she still has the right bundle, but this is atrial fibrillation, not ventricular tachycardia. Now, she may need to be cardioverted because people with severe aortic stenosis don't really tolerate tachycardias, but this is not VT. Here's a 25-year-old man who complained of lightheadedness. He has this widely, irregular, wide complex rhythm that it seems like it changes all the time. This is not polymorphic VT. What is this? It's irregular, rapid irregular, wide complex, mostly. This is atrial fibrillation in a patient who happens to have WPW. So you can't really see the slurred upstroke. Here's maybe a couple of examples of the slurred upstroke. So this person should be cardioverted to normal rhythm, and then he should go directly to the electrophysiology lab and have his bypass tract ablated, because this is a dangerous finding. Now, what's going on here? We have this wide complex rhythm, you'll notice. Look down here at the lead tube and the rhythm strip. And you can look here also. These are This is a ladder diagram. To produce a ladder diagram, you draw 4 horizontal lines. You mark off all the P waves. So here, 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 here. Okay. And then on the bottom, you mark off all the QRSs. So here, here, etc. And then look what happens. Um, there's this PR interval, 0.32. This PR interval, which is much shorter and the beginning of a wide complex rhythm. So this is probably dissociated in the beginning of a ventricular rhythm. And you notice that P waves look like they come, well, this, here, see, they sort of come out at the end. Here's another P wave that's on top of a QRS that clearly isn't conducted. So this is but the rhythm, but the rate here is slow. The rate is it's not perfectly regular, but somewhere around 65 to 75. This is accelerated idioventricular rhythm with AV dissociation. It does not require treatment. So don't get this confused with ventricular tachycardia. Okay. So finally, my approach to arrhythmias is look at the patient, look at the EKG, look for and treat precipitating or reversible factors, and treat the arrhythmia if necessary. But in the case of atrial fibrillation and atrial flutter, prevent thromboembolism, and no drug toxicities in terms of drugs that prolong the QT interval. And with that, I'll leave you with my parting shot. You have clogged arteries between 6 and 9 a.m. and 4 and 7 p.m. on weekdays. And thank you very much. I'll be glad to entertain questions. Oh, we have some questions? Oh, we have a couple of thank yous. I appreciate it. Thank you very much, folks.
I'm just going to put a couple of things in the chat.
Okay.
So just a reminder about the CME survey that it will appear in a tab when you close out of this webinar. We really appreciate you taking a few minutes to complete this. Not only does this give you CME credit, but also helps us to plan the best session for you. We share the feedback anonymously with the speakers, and they greatly appreciate your thoughts. If you have any questions, you can put them in the chat or in the Q&A. Let's give it a couple more minutes. I also put in the chat about, we hope you enjoyed today's session, are interested in attending future sessions, or even anchoring an educational session. All clinics can anchor an educational session, which means you get to pick the topic, date, and time of an educational session. The only requirement is that someone from your clinic attends the session. If you're interested in becoming an anchor, we would love to schedule your session. You could either submit the education session request form on the clinic portal or email ktalbot@mavenproject.org. And all of that is in the chat. And just a reminder that MAVEN Project offers mentoring to all of our community providers at any point in your career. Some topic ideas to reference: new to practice providers, challenging case review, preventing burnout, building teams, and executive coaching. Also, we offer specialty specific mentoring like EKG or CGM, or reference the topic of today's ed session.
So apropos of today's talk, I'll just give you an example. I am mentoring a nurse practitioner in Indiana who sent me a cardiogram that she was concerned about. Well, she actually sent me the ambulatory ECG monitor that she was concerned about, and it had a very scary looking ventricular tachycardia, for which I told her to send him to the emergency room. She was inclined to do that anyway. You know, it reinforced her you know, she wasn't feeling confident about it, but I was able to reinforce that for her. And the patient went to the emergency room. I don't have a follow-up, so I can't tell you what happened.
Well, I don't see any questions coming through, but thank you, Dr. Schulman, so much. It was a great presentation.
Okay, well, thank you, Jennifer. It was a pleasure to see you guys,
Yes.
as always. And we'll look forward to the next time.
Yep. Okay. Hope everyone has a great day.
Okay, take care, everybody.
Bye.